On this episode of the Athletic Potential Podcast, we'll be discussing how to deal with cranky wrists during training, as well as the key factors in returning to sport following ACL reconstruction surgery. Welcome to the Athletic Potential Podcast, your place to come and get answers to your athletic development questions. We cover a range of topics, all related to helping you to achieve your athletic goals so that you can experience and enjoy the athletic career that you deserve. I am your host, Dr. Mike Mathews. Hey everybody, and welcome back to the Athletic Potential Podcast. We're excited to have you here this week. Excited to have these topics and again answer questions and try and get good information out there. We really appreciate everybody who does listen to the podcast and appreciate your support. So we're going to do a couple different things today. I shouldn't say different things, but we're going to answer a couple questions. But the questions we have today are interesting in the sense that I feel like at least one of the questions, it could go about 25 different ways. And I can tell you for sure that there are entire almost conferences on one of the topics with tremendous amounts of research that are covered. And I'm going to try and give you a succinct answer of the things that I typically see overlooked in traditional return to sport. We'll get into that. And the first one's is kind of a fun question. And so we're going to jump right in. So our first question comes from Kevin. Kevin asks, what do you do when you have cranky wrists during training? More specifically, I am unable to perform push-ups because every time I go down into a wrist position or put my wrists down on the ground in an extended position, I have pain in the backside of my wrist that limits me. I am able to go and do push-ups with fists, but unable to put my wrist in extension without increases in pain. Any suggestions on what I can do? Kevin, this is a great question. And depending on where the pain is on the backside of your wrist will determine really how we want to target this. Most pain that comes from backside wrist pain, when we say backside wrist pain, for those that are watching, it's on this side of the hand. So I would always say, if you take your hand and put the palm facing you, if the pain is on the backside and in the middle of the wrist, in the middle, okay, not to one side or the other, but in the middle, then you're dealing with a specific type of wrist pain. Now, it could be a lot of different type of things, but in my experience, what it is in that region, there's two layers of bones, okay? They're called the carpal bones. They're essentially, they're not long bones. They're round type bones. They're really all sorts of shapes, and they've got some cool different shapes in them and congruencies, and that allows your wrist to move in a lot of different ways. And the idea is that the bones are essentially allow us to be able to grip using our hand, and then to be able to contour our grip to the environment because of the way the wrist is put together. That being said, since there are multiple bones on each layer, okay, all those bones are, well, I shouldn't say all the bones, but select surfaces of those bones are covered in cartilage. And when you have cartilage, then you have ligaments that also holding those areas there. And occasionally what can happen is that due to repetitive overuse or extension, repetitive push-ups, lots of them, falling on your hand would be more of a traumatic example. But if you have those type of things, what can happen is, one, you can pinch a ligament, or two, you can impact the surfaces that have cartilage on them. And when you do that, you can create a pain type scenario. And what happens is, most often than not, if you pinch a ligament, it gets better a little bit more quickly. And if you pinch or cause some, it's almost typically a bone bruise type scenario to the cartilage area or to the bone, then what happens is that pain will stick around longer, and you won't be able to get into those positions because the pain will return quite quickly. And that is typically what I see when we talk about training type injuries. So if you're in the gym and you're doing push-ups and you're doing presses or whatever, and all of a sudden you get in this backside wrist pain, you can't get into those positions again, that's typically what the case is. Now, if for those that have listened to the podcast in the past, you know that basically what I like to do is, if I have someone comes in and they're complaining of pain, in this case, the backside of your wrist, it's you, Kevin, right? And I try to identify what anatomical structure we're dealing with, and that would be ligament, bone, tendon, muscle, nerve, capsule, those type of things. And based on that, if I can identify which one of those or multiples of those we're dealing with, will give me an idea of how long it's going to take for that to get better. Now, And typically in this case, what we normally have seen is it's some sort of something impacting either the ligament or the bone. When we talk about bone, typically we're talking 4, 6, 8 weeks for it to recover, so long as you're not continually making it mad by forcing your wrist into extension. Now, I'm not saying you can't do anything for 4 to 6 weeks. As a matter of fact, you're going to hear me tell you to do something very opposite of that in regards to treatment of this. But that would be one thing. I'd be like, it's bone. It's going to take a little bit of time. We're going to have to avoid some positions. Yes, those type of things. If it's ligament, we're talking 4 weeks in the sense that you didn't actually like tear it or have some more substantial problems. If you just irritated it, then yeah, we're talking like 4 weeks where you're going to be dealing with it, but you're going to be able to function. And so, Kevin, my first and foremost suggestion is you've got to avoid the painful position. So just immediately forcing yourself into wrist extension, doing push-ups, I think it was what you mentioned, is only going to aggravate it. You already did the solution, which is, hey, I can do push-ups on my wrists or on my fists, and that puts your wrist in neutral, so we're now staying out of that extended position, which therefore doesn't create any of that pain. So that would be the first thing I would tell you to do, and you did it already. Great. Now, we can do a few more things that will accelerate the healing of the ligament and or bone. Now, one of the things we know is that if you affect an articular surface, now articular just means cartilage or touching surfaces, right? So it's going to be cartilage there, and those two surfaces touch. And anytime we have two bones that like to touch together, there's typically cartilage in between them. Okay, not all the time, but most of the time. And in the wrist, that is the case. And so if that's the case, the way that cartilage, and I'm glossing over some massive biology here, okay, so I'm just trying to simplify it, but the way that cartilage gets nutrients is through compression and decompression of the joint. So if we're not using, and say we put, you see this treatment all the time, and I understand why it's prescribed, because if you're in lots amount of pain, you've got to protect the area, you've got to give it time to heal. And so you'll see people that go in wrist brace, and they'll tell you, like doctors will say, or whoever will say, hey, I need you to wear a wrist brace, that's why your wrist hurts, I need you in it for 4 to 6 weeks, just wear it there, the pain will go away. And the answer is yes, it will. And maybe that's the right course of treatment for you. It's not the course of treatment I like to prescribe. I like to use a wrist brace in select cases where you're going to have a really hard time avoiding that position. So maybe we need you to rest a little bit more often, and maybe your job doesn't require you to do that. Construction or more of a manual labor job, you're going to wear a wrist brace during that time period, okay? Because that's going to keep you out of extension. I don't believe in wearing it 24/7. I feel like what happens is when you wear it 24/7, you're not moving the wrist. You're essentially causing atrophy and some disuse movement problems because you're not using the hand and the wrist in that position. Now, remember, we're talking about pain that hurts when you're in wrist extension, typically with your hand on the ground. If that's the case, you avoid that. You avoid the wrist brace so long as it doesn't hurt during anything else, and you don't have any of these other disuse or atrophy type problems because you're avoiding the pain anyways. Okay, so what I like to recommend is, remember, compression, decompression is what creates or provides nutrients to cartilage that may need it. And in this case, we're going to do the opposite of what hurts. And that is, we're not going to put you in extension. We're going to put you in neutral. We're going to have you grip, and we're going to have you hang from a bar. So if you hang from a bar like you're doing a pull-up or something along those lines, and that's going to distract the wrist joint. And when we say joint, remember, it's all those bones that are put together. We're going to create space between those bones, and then you're going to come back down off of it, and then you're going to go back up into it. I like to start right around 5 to 10 second holds, working your way up to essentially, cumulatively adding up to about a minute. And then eventually what you'll do is you'll get to the point where you'll hang continuously for 30 seconds, and then you'll take a break and then hang again for 30 seconds. And that is the longest duration I recommend, because I don't typically see benefits outside of that. And so I think if you did that, worked on hanging, that decompresses the joint. And then when you come down off of it, it compresses the joint. And now we're getting nutrients, right? Into the area that needs it. So that's where I would start. Okay. Kevin, so I'd start with that. I'd start by putting your wrists in positions that don't hurt and keeping it there, but staying as active as possible. You're already doing that. Push-ups on your fists, and then any other movements that you're avoiding pain, but you're trying to modify. Good. You've done that right. And then I would do hangs. I would hang from a bar or hang or anything like that to decompress it. Now, I know I'm going to get this because I get this from everybody, and that is, hey, 1, I don't have a place to hang, or 2, I really don't like hanging. I can't hang on for very long. or 3, it's just not comfortable for me to hang. So I say, great, there's another solution to this. And that is you're going to pick up a weight, preferably like a kettlebell, farmer's bar, something where the weight exists below the grip. Okay. Now you can even use a bag if you wanted to. Okay. You don't need like just something with the handles on it so that the weight sits underneath. I don't like dumbbells for this reason, because the weight is now between the hand and now you're having to do wrist work to maintain wrist position, and we want to avoid that. So I like anything that hangs down. Okay. So kettlebells are my favorite. Okay. They just are. So what you're going to do is pick up a kettlebell and you're just going to walk with it. Just kettlebell walks or farmer's carries or whatever you want to call them. And that is creating, again, that distraction of the joint. And that's what we want. Okay. So you can hang from a bar. It's my preferred method. Okay. Because, well, if you know anything about the way I like to treat, I don't like just treating one thing at a time. I like trying to improve the maximum amount of things I can in the shortest amount of time, or in the least amount of exercise. And hangs have tremendous value other places. Okay. But if you can't hang, or if it's just uncomfortable, or you don't have a place to do it, then you're going to grab a weight and you're going to carry it. Okay. And then that's going to help with your decompression. Again, you're going to carry it for a certain distance, typically right around 30 seconds at the maximum. Then you're going to put it back down. And then once you're done with that, then I want you to do it again, cumulative of a minute, a couple times a day. I'm willing to bet you're going to start seeing improvements. Okay. Now, if you were to come in and see me, essentially what would happen is I'd give you that same exercise that we just talked about, but then I'm going to add 2 more things that I think are highly effective. One is a type of electrical stimulation that is going to, 1, desensitize that area, so you're going to have less overall pain, and 2, it's going to push a massive quantity of blood to the area. Again, I can't force blood into bone or anything, but I can compress and decompress, and I can teach the muscles surrounding the joint to basically take the load off of the wrist a little bit. Now, it's not exactly what happens, but realistically what happens is that we allow the forces to dissipate. Rather than going through one spot in the wrist, we teach them to dissipate or go through muscles, and to allow the muscles to take on more of the force. Okay. And when we do that, that decreases the pain, it decreases the compression, and allows for things to heal a lot faster. And we maximize blood flow to the area, and your pain levels go down. So that is one of the things I'll add to it. If it's more of a ligamentous type problem, I like using dry needling for this, because then we can target the ligament directly, and it seems to work a lot better if it's more ligamentous. Bone, I haven't seen a ton of, well, I shouldn't say that, because I've definitely seen some improvements with dry needling with bone type scenarios, but I can tell you it's not my favorite thing to do in the wrist. There's a lot there. I don't like to put needles in a wrist unless I know exactly what we're dealing with, because there's a lot of other things that probably don't want to be poked that are living in the wrist. So anyways, Kevin, I hope that answers your question, gives you some direction. If you're having a lot of troubles with it, give us a call. We're happy to walk you through it, whatever that looks like. And hopefully it helps. Okay. So we're going to move on to our next question. This next question is one that probably could take, the better part of a semester in college to teach. And there's research going, always seems like it's coming out. And I can tell you right now, from the time I was in PT school to the time now, I feel like I've changed my mind 7 different ways in regards to how to do this. So let's get right into it. And this question comes from Paul. And Paul asks, I recently had a daughter who had an ACL reconstruction surgery. She has been doing well in her rehab, getting her range of motion back, and her pain levels seem to remain low. She is just now starting to work on more heavy strengthening type exercises and seems to be doing well with those as well. The doctor suggests that we start jogging around 3 months, and then potentially can return to play anywhere from 6 to 9 months. Okay. Are there things that are most important for you when you are rehabbing female athletes following ACL reconstruction? And if so, what are they? And any additional information you can give me would be much appreciated. Sorry, my screen is like, it's hard to read. I don't know what it is. I've been trying to work on it. Sorry. So I'm just, every time I move it, it jumps. So apologize. Okay. Paul, this is a highly controversial topic. I feel like we talk about it all the time. There's a lot of things I don't know about this, but I think it's worth talking about. Okay, Paul, so let's start with this. The type, you already talked about the first things, but the key factors right out of surgery for me, you want to get rid of all the swelling as fast as possible. The pain levels need to be 3 or below at all times. Okay. And you want to achieve maximum or full range of motion as soon as possible. But just notice what I just said. You got to get pain levels 3 or below. So we're not jamming on range of motion to get all of it as fast as we can and allowing the pain levels to skyrocket. We're talking about getting rid of all the swelling. Well, a lot of people like to use ice and all this kind of stuff. And if you listen to my podcast before, I don't believe in it. I don't think it does the job that we think it does. And I can tell you my results have been dramatically better in those that we don't ice. So anyways, when we use trying to get swelling and those type of things out, there's techniques that we use. And you got to get swelling out of the knee. We've got to get the pain levels low, and you want to achieve maximum range of motion as soon as possible. Okay. Now it sounds like you're already working through that, and I'm assuming you're working with a rehab professional, and it sounds like you're making good progress. This is good news. If you haven't hit those 3 things, if there's still swelling, the range of motion isn't there yet, or the pain levels continue to stay higher, I would suggest that maybe you change the treatment or the course of the treatment for the next little bit and achieve those 3 things. Because what we found, at least I have found in my experience, and the research would back me up on this, is that if those 3 things are not addressed early, then we're going to run into problems down the road. Okay. Persistent edema is not a good sign. It inhibits quad function, depending on which research article you read, and can limit your ability to achieve full extension as well as flexion, but definitely full extension. Okay. So we want to get rid of all that. So that being said, say that's all there, and you've progressed beyond that. Your daughter's progressed beyond that. And now we're starting some strengthening exercises. One of the things that I've been incorporating more often, I would not say more often, with nearly all of the athletes that I treat that are trying to return to sport after surgery, is we look at what we call EMG. EMG is essentially how much electrical activity is occurring in the muscle that we're targeting. Now, in the knee, following ACL reconstruction, you'll know, because you know what muscle you should be targeting, because you'll look at her and go, whoa, where did your quad go? Right? It's the muscle on the front side of the thigh. You're going to be like, it's smaller, a lot smaller. We call that quad atrophy. It's also a massive problem in regards to returning to sport. And that is something that we address. Well, I should say all the 3 things we just talked about: pain, range of motion, and edema. And then I'm going to add in atrophy, analogical or EMG loss, or the inability for the muscle to contract itself. Those 5 things I immediately address. When I say immediate, I mean like day 1 post-operative. We're doing things to mitigate loss of muscle size. Loss of muscle size is atrophy. Okay, we're doing things to mitigate that. We're doing things to get pain levels down. We're doing things to turn the muscle back on in the quad. We're doing things to try to promote edema, reduction, and we're doing things to try and improve range of motion. So those things are happening literally like day 1, day 2. And I know I got people out there that are listening to this. Gosh, dang it. Sorry, I just almost ripped my headphones off there. It's been a good technical day here at Athletic Potential. So one of the things, I get all the time is, well, how am I supposed to do that? My leg is wrapped up. It's totally just bandaged up from, foot way up my thigh and way down my leg. And the answer is you do your best. You do your best. We had one of our clients that had an ACL reconstruction. We were doing electrical muscle stimulation on her above where her wrap ended, and we were doing things below where the wrap ended, and we were working on extension immediately, trying to see if we could get her knee straight, and did so in the, even with their knee fully wrapped up. So there's ways to do it. Okay. And it's worked. I can definitely tell you in multiple cases, it has absolutely worked. So sorry. Like I said, almost an entire semester on this stuff if we wanted to. So moving on. One of the things that I look at heavily, and I have looked at heavily in all of our athletes that are coming back after surgery, is EMG. We want to make sure that select muscles are activating, or we're getting electrical activity to those areas to allow muscles to function. So one of the reasons the quad atrophies following the surgery of ACL reconstruction is that you get this quad inhibition. It's essentially a shutdown of the nerve, electrical activity from the brain to the muscle, or from the spinal cord to the muscle, depending on who you talk to, right? So it shuts it down. It's called inhibition, and it doesn't allow the quad to fire. I think it's a protective mechanism of the body, and it's a major problem. And we use EMG to quantify how much electrical activity is actually going to the quad. I can tell you just more recently I was just reviewing a case that we had from someone who was coming back off ACL reconstruction, and they had a 65% deficit in EMG from their surgical leg to their non-surgical leg. Okay, that means that they were only getting 35% of the normal muscle activation that the other side was getting. 35%. That's nothing. Like, it's not going to go well, right? And so one of the things I would tell you is if you are not monitoring, Paul, if you're with your daughter, if you're not monitoring, obviously range of motion, do that. But if you're not monitoring EMG, I'd highly consider finding a way to do that, because it made a massive difference, and it has made a massive difference in nearly all of our athletes. We do the same thing with the flexor pronator mass in baseball players here. For those that can see in the video, I'm pointing at the inside of my elbow and my forearm. It's kind of that big mass of muscles there. And we do EMG on that to make sure that muscle comes back after Tommy John surgery, because it seems like sometimes they have issues with that, and it's the main mechanism or the main group of muscles that protects the ligament in that area. So EMG would be one of those things where I don't feel like a lot of people look at. It does require some technology. If your rehab specialist doesn't have that type of technology, maybe you can find somebody who does. But I definitely think it's worth it. It's something that we have seen dramatically change the way we rehab a lot of our athletes that are going through this. Is it allows us to say, you know what? Hey, look, you're getting more range of motion. Your pain levels are down. Your edema's gone, but your EMGs are terrible, and your strength numbers are not there either. And that would be the next thing I tell you, is that you got to measure strength. For a long time in my practice, I didn't really measure strength. I didn't quantify strength. There's things out there we call manual muscle tests in the physical therapy world. And essentially what you do is you have somebody, you push against someone. So maybe they're holding their arm out and you're trying to push their arm down and they push their arm up, and it's supposed to measure strength. We're supposed to, I believe that, I can't remember the definition was because I forgot it. But the idea is that when we push down, we grade it. We give you a 5 as a normal. You have normal strength, 4 plus, 4 minus, and there's different things, and it doesn't matter. But the idea is that what I found is when it comes to strength following surgery, that doesn't help, because our manual muscle tests aren't strength tests. I like to call them weakness tests. They're trying to detect weakness. They're not trying to quantify or measure strength. Okay. And so, we've got ways here that we test strength. And I know that's a whole can of worms and how accurate it is and everything, but realistically, you've got to be able to pre and post test, either in session or between sessions or between time periods, pre and post test, and replicate that test. Because what you're looking for is the side to side symmetry. And if your non-surgical leg, it remains to be quite a bit stronger than your surgical leg, then you need to get the strength level up in the surgical leg. Okay. And so measuring strength is a big deal. And it's something that, especially since I've opened Athletic Potential, it's something I do with nearly every athlete in every session that we work with. Okay. Or that they're in here working with me, is we measure all things strength to make sure that what we're doing is actually impacting them in a positive way in regards to building strength. Okay. So make sure that, so EMG would be one of the things. Find someone that can measure EMG, make sure that it normalizes side to side. So your EMG numbers are both peak EMG as well as average EMG. Make sure that both of those are similar. Okay. Side to side. And then you want to measure strength. And you can measure quads, hamstrings, glutes. You can measure everything, squats, just general movements. Doesn't matter. Pick which one. In ACL reconstruction, I like to measure everything you just said. Quad, hamstring, and then I like a general deadlift, single leg and double leg. Okay. They have force plates and everything for this. It works fantastically. It's good. You want symmetry. Okay. Get symmetry. So find some way to measure strength and quantify it. Okay. And Okay, so yeah, we've got range of motion. Talked a little bit about EMG for sure, strength for sure. Make sure there's measurements there and that you're getting it symmetrical. Okay, one of the things that let's put it this way: I don't allow, or I highly suggest that my athletes don't return to sport if they are continuing to show substantial atrophy in their leg. I cannot tell you what the evidence suggests on this. I know that it suggests that if you have normal quad size that it's better, but I can't tell you exactly. But I can tell you this, that of all those that I've rehabbed following ACL reconstruction, and it's been quite a few, the ones that have done the best are the ones that they walk out, and most of them, I'll be honest, female athletes, most of them have been soccer. So if they walk back out onto the field to play soccer and you're in the stands as a spectator and you go, dang, I can see a difference in her quad size, right? That to me is like a failure to return. Like you just don't return at that point. If you can see quad size differences from a spectator's vantage point, that's not good. We've got massive quad atrophy there. That's not okay. You're at higher risk. And so that's one easy way to, Paul, to test this, is just to look at it from a distance and be like, yep, that quad is much smaller, right? Now, if you're in a spectator's distance and it's kind of like, maybe, then that's better. But realistically, you should be standing next to the athlete, look at them, look at their quads and just go, oh, you had surgery only because I see a scar, not because your quads are smaller. And this is a battle. Like this is one of those things where if you do it right, you can get it back for sure. But a lot of times it takes substantial amounts of time, effort, the right amount of training, the right type of training, additional things to really ramp up and get this atrophy and get that quad size back. And it is worth every bit of the effort if you can get it. Okay. So Paul, we're talking about range of motion. Make sure you measure that. Strength, measure that. EMG, measure that. Atrophy or quad size, make sure the muscle size gets back. That's something that I think it's stubborn, it's hard to get. And unfortunately, a lot of clinicians and even, practitioners are just like, you know what, it'll come back. Don't do that. Get it back. Don't go back to the sport until it is pretty much back. At least use the spectator, test. If you can see it from a spectator, it shouldn't be playing, in my opinion. Anyways, I know I'm going to get some backlash on that. That's okay. And, what else would I suggest? That's not typical that we would hear. So you mentioned something in your question, and I apologize. I look at it, but my screen's going to go, and I don't want to do that. And I think you said something like they returned to jogging at 3 months. By the way, none of my athletes that work with me following ACL reconstruction are jogging at 3 months. And it's not because I don't believe in it. It's because I really don't like the idea of a jog. I like purposeful running, because jogging can get, what do they call them? Garbage miles is what somebody called jogging the other day. Yeah, you're just putting garbage miles in. Sorry for those people who like to jog. I'm not trying to diss on it. But in regards to this context with ACL reconstruction, I like purposeful running, form running, conscious effort with running to make sure that the form is good, that we're muscle activating correctly. And I don't just pick a time frame, be like 3 months, we're good to go. You don't start jogging, or in our case, running, because I don't use the word jog to emphasize the fact that it's purposeful running. Okay. We don't start running at 3 months unless you've passed the return to run tests. If you don't pass the return to run test, you don't run. Okay. I don't believe in time frame running. It's 3 months, go ahead and start running. I just don't like it. Okay. We see issues, we see problems, we see biomechanical flaws, bad habits that are formed, pain increases. Okay. We don't do it until you pass the test. Okay. So sorry, a little bit of a tangent. So just because 3 months is around doesn't mean you should be running. And I think I saw something about a 6 month return. I am hearing this, and maybe I'm missing a massive research, part of the research with this, but everything that I've read suggests the earliest return should be 9 months, period. 9 months. Anything earlier than that seems to be asking for problems down the road. And even at 9 months, it's still problematic at 9 months. I can tell you this, Earlier returns are nice. Everybody likes them because, I'm back and play. I'm no longer out of the game. I can play again. But what we do know is that there's a process called ligamentization. It is the reason why all of this takes so long. Okay. It's called ligamentization. And you essentially, in most cases, they're using hamstring grafts so just to lay it out to you, Paul, you probably know this, but for those that are listening, typically when you do an ACL reconstruction, they're going to take a different tissue from your body. It's either going to be a part of your hamstring tendon. It's going to be part of your patellar tendon. Okay. We've seen gracilis tendons. We've seen Achilles tendons. We've seen quad tendons. Okay. They're going to take some sort of tendon, part of a tendon out of you and replace your ACL, which is no longer, with that tendon. Okay. And what I just told you is they just replaced your anterior cruciate ligament with a tendon. And there's a process that has to happen from a tendon because a tendon's biological makeup is not the same as a ligament's biological makeup. They're similar, but not the same. And there's a process called ligamentization. It takes a while. And what we do know in ACL research, it seems like it's still happening at 12 months. So a 6-month return tells me that that ligament or that tendon is still more of a tendon than a ligament, maybe. We don't really know. It's tough to study. But at 6 months, we pretty much know that's probably that ligamentization process is still happening. That ligament is still susceptible to excessive stress and loads because it hasn't changed yet. And even at 12 months, we know it's still happening. And I think there's research out is 15 months. And again, I might be missing a part of this, but I've heard of this where people come back at 6 months. I don't agree with it. I can tell you right now, I have daughters. And if my daughter ever had to have an ACL reconstruction and nothing has changed in regards to like advancements in medical terminology, but if she had an ACL reconstruction and she was at 6 months, I would not allow her to return. Even if the doctor's like, yeah, I think you're good to return. No way. It's not happening. I've seen the research. I've seen the results. We see problems with this, and maybe there's better therapists out there, and I'm sure there are. But anyways, the point is that the research to me is pretty strong. 9-month return is the earliest, and even at 9 months, you still consider putting it maybe at 12 months. I tell all of my clients, this is a 12-month return. If you tore this thing on July 1st, if you tore this thing in July and you had your surgery on July 15th, your return date is July 15th of the following year. It's what it is. I know it sounds terrible. I did the same thing with Tommy John, right? By the way, that's a ligamentization process right there. Same thing, takes 12 months. Anyways, but the point is it takes a year. I tell them it takes a year. And then what happens is over the course of that next year during the rehab process, it really, depending on effort, time, biology, and really just how things go, will determine if you're at 12 months, if you're early at 9 months, maybe, or it may take 15 to 18 months. We've seen that too. Okay. So Paul, I know that doesn't help you per se, but as a general overview, where you were asking like, what things do I look for? I'm kind of just like taking whatever that's off the top of my head and just kind of giving it to you. And I hope that helps. And let me emphasize one more thing. And I'm just going to tell you like best case scenarios that the athletes that I have helped with and helped them return back to sport following ACL reconstruction. The most successful athletes at this process took this time, and we're going to say 9 months at minimum, so 9 to 12 months. They took this 9 to 12 month window and they reinvented themselves as an athlete. If you've listened to my podcast in the past, this is nothing new. You've heard me say this before. Same thing happens in Tommy John with the baseball players. Okay. But look, this is time typically that the athletes have never taken to spend time getting good at all the things that they suck at. If they've had strength deficits this entire time and they couldn't really commit themselves to a solid strength conditioning program for long enough because their competitive season is year round, guess what? You have 9 to 12 months to dedicate yourself to getting yourself as an athlete, or Paul, your daughter, to be the best athlete she can be, to build her into the better, she should come back after this process a better athlete than she was before. stronger, more mobile, knowing how to move better, better balance, better core strength, all of those things. She should come back a better athlete than she was before the surgery. That is something that I highly emphasize with all of my clients that I work with. I tell them, like, look, you have time, and we're going to use every minute of it to make you a better athlete than you ever were before. You should get back and be better than you were before. That is the goal. And the athletes that take this serious and do the work, and it is a grind. I haven't gone through it, but I can tell you right now, the athletes, it's a grind. It's a grind. But the athletes that do the work and are consistent throughout the entire process and follow a plan are the ones that get back and are better athletes than they were before. And we've seen it time and time again. Time and time again. We just, one of our athletes who had ACL reconstruction surgery returned at 9 months. She passed every test. Her quad size is almost the exact same as her non-surgical leg. And she hit the field, and according to her dad, nobody could tell that she had surgery. Nobody could tell. She was beating girls to the ball. She was in positions and fast, and the only thing that they could really tell is her endurance was terrible, right? But okay. But the idea is they couldn't tell. They could not tell. And that's the way it should be. So, Paul, I know I just gave you a lot. I just gave you a lot, and just off the top of my head, so nothing's really organized, and I apologize about that. I try to be more organized than that, but your question kind of just stirred a lot of thought and a lot of different things, and I hope that helped. We talked about, get normal range of motion, test for strength, make sure the EMGs are symmetrical from side to side, make sure the size of the muscle is symmetrical side to side. And wherever you're at in this process, Paul, I don't know, it sounded like you're a couple months in maybe with your daughter. One of the things I would highly suggest you do is you look at a way to help your daughter to become a better athlete than she was before this happened. Get her a good training program if she's not on one already. If she's in rehab and you're doing rehab exercises and you're not training the other leg, and you're not training balance, you're not training core strength, and looking at all these other things that she could be improving on, you're missing out. I would say the rehab side of this, if she's just doing the rehab exercises, that's like 20 to 30% of what she could be doing. She needs to be doing a lot more. But find a way to make this unfortunate opportunity a good opportunity to make her a better athlete. And I think if you do, she's going to be much happier. She's going to be able to stay in her sport. I don't even know what her sport was. I apologize. She'll be able to stay in her sport longer. She'll be able to enjoy athletics longer. And to be honest, down the road, hopefully, the ACL reconstruction won't be causing problems down the road. You won't see any problems in the knee following this because she came back better. So, Paul, I hope that helps. Sorry for everybody just listening to me rant right there, but it is important that I feel like it's important that we talk about it so that we can understand really what can be done with these athletes, especially those that are returning to sport. I think it's important, again, to note that there are opportunities here. Opportunities. And I hate to tangent again, but The Gift of Injury is a fantastic book by Stuart McGill, and I believe Brian Carroll is a power lifter. It talks about Brian Carroll's struggles and the fact that he essentially just broke his back with powerlifting. And he talks about taking it and making it an opportunity for him to reinvent himself as an athlete, as a power lifter, and to come back better than ever he was before. It is a fantastic book. And The Gift of Injury is what it's called. And unfortunately, an injury is no fun, but it can be a gift. It can help. If you use it as an opportunity, it can definitely accelerate your athletic career and not end it. So anyways, I appreciate everybody listening. I appreciate everybody tolerating my rant, and I hope everybody was able to get something out of it today. If you do have questions, again, ask your questions. It's a question-driven podcast, and I'm happy to answer them. We did have a request the other day, which I thought was fantastic, for basically what is your take on a subject, and please use your knowledge of the research. They really wanted more of a kind of a nerd approach or a geeky approach, right? And I appreciate that. That is coming, but just so you know, if you're waiting for that, and you're like, why isn't this coming out? Just so you know, it takes time to research those things. If I'm going to look into research, I really want to try to, essentially give you good research and to give you good information and up-to-date research as much as I can. But that does take time and energy and effort, which is just totally fine to do. But you just be patient. We'll get them out, and I'll try to have those more research-driven podcasts here in the future. I am working on them now, but just so you know, that is happening. So if you're listening and you're like, hey, why haven't you answered my question? That's why. And anyways, I appreciate everybody listening. And again, if you have questions, ask them. And I appreciate taking the time. And we'll catch you next time. Thanks.